Hello and welcome to this session. In this session, we are going to look at systemic pathology. So, in systemic pathology, we have a number of objectives. Number one is to give a brief overview of the normal structure and function of the vascular component of the cardiovascular system. We need to define what is hypertension emergency, what is hypertension urgency, what is primary hypertension, and what's secondary hypertension. Lastly, we'll be able to describe the nursing care of a patient suffering from hypertension. We can define some terms like the systolic blood pressure. This is the higher number in blood pressure reading and normally represents the pressure in arteries when the heart beats and pumps blood. Diastolic blood pressure, on the other hand, is the lower number in the blood pressure reading. It represents the pressure in the arteries when the heart is at rest between beats. Primary hypertension is also referred to as essential hypertension, as we can see, and it's the most common type of hypertension with no identifiable underlying cause. It normally develops over time due to combination of genetic and lifestyle factors. Secondary hypertension, on the other hand, refers to hypertension that is caused by underlying health conditions, could be due to the kidney, hormonal disorders, or side effect of certain medication. Isolated systolic hypertension, abbreviated as ICH, is a condition in which only the systolic blood pressure is elevated, often seen in older adults, okay, and can increase the risk of heart diseases and stroke. White coat hypertension is a phenomenon where a person's blood pressure readings are normally higher when measured in a medical setting, okay, and this is probably due to anxiety or stress but are normal in other settings. Masked hypertension is a condition where a person's blood pressure is normal in a medical setting but is elevated outside the setting, leading to underdiagnosis of hypertension. Lastly, hypertensive crisis is a severe increase in blood pressure, typically defined as systolic blood pressure higher than 180 millimeters of mercury and or diastolic blood pressure of more than 120 millimeters of mercury. Hypertensive crisis requires immediate medical attention to prevent organ damage. It may be urgency or emergency. So generally, hypertension, as we have briefly talked about, is defined as blood pressure greater than 140 over 90 millimeters of mercury on 3 consecutive doctor's office visits. And pre-hypertension blood pressure will be ranging between 120, 139 or over 80, 89 millimeters of mercury. So in long-standing severe hypertension, one may note hypertensive retinopathy, including narrowed arterioles or even retinal hemorrhage or exudates. Cardiac enlargement could result from hypertrophy and may be noted as displaced and prominent point of maximal impulse on cardiac palpation. An S4 may be had on cardiac auscultation and it normally comes before the S1. So instead of having the normal one lab dab, we could have ta lab dab. It's good to note that S3 will be common in heart failure, okay? And if it is there, it will come immediately after S2, after the dab. Complications of hypertension include accelerated atherosclerosis, resulting in ischemic heart disease, thrombotic strokes, cerebral hemorrhage, and renal failure. In severe hypertension, encephalopathy may occur, and the patient could present with CNS symptoms. It's good to remember that the most common cause of hypertension is essential hypertension, and salt sensitivity may be a contributory factor. Other most common causes could include diffuse renal disease, medications, renal artery disease, and neurological disorders. While other less common factors could include coarctation of the aorta, mineralocorticoid excess, glucocorticoid excess, and catecholamine excess that can cause hypertension. It's good to know that the blood vessels are normally a closed system of various conduits that carry blood from the heart to the tissues through the lungs and back to the heart. So all blood vessels are lined by a layer of endothelial cells, which normally secrete substances that will affect the diameter of these vessels and provide their growth, their repair, the formation of new vessels that can carry blood to the tissues. So the vessels vary in diameter, thickness, and length. So as the diameter of vessels decreases, their number in the body also increases, so as the total cross-sectional area increases. Looking at the arterial vessels, it's good to know that there are various layers of the tissue that make up blood vessels, and they are structured in circular rings. If you pick out an example of the arterial vessels, such as the aorta, large arteries, and arterioles, they are normally made up of an outer layer of connective tissue, which is referred to as adventitia, followed by a middle layer of smooth muscles, referred to as the media, and lastly, the inner layer of containing the endothelial cells and subendothelial connective tissue known as the intima. So we have the adventitia, media, and intima, okay? AMI, correct. So the walls of the aorta and large arterioles contain abundant elastic tissue. Much of it is concentrated in internal elastic lamina, and this is just a prominent band between the intima and media. And on the other band is the external elastic lamina. Okay, external, and this external one is found between the media and the adventitia. So the vessels do stretch by the force of cardiac ejection during systole, and the elastic tissue permits them to recoil during diastole. So this maintains diastolic pressure and aids the forward motion of blood. The walls of the arterioles contain less elastic tissue, but more smooth muscles, which are innervated by the constrictor non-adrenergic nerve fibers. In some instances, there is a vasodilator cholinergic innervation. So the vessels and the arterioles offer considerable resistance to blood flow of blood, and therefore are referred to as resistance vessels. What about the arteries? This is another group of blood vessels, and these are the terminal portions of the arterioles. Okay, that where now these terminal portions of the arterioles drain. Okay, so on upstream side, the openings of the capillaries are surrounded by smooth muscle precapillary sphincters. The capillaries themselves are made up of single layer of endothelial cells. The capillaries anastomose extensively. Veins are similar to capillaries and are their approximate total cross-sectional area of about 4,000 squared centimeters. They drain into veins, which drain into superior and inferior vena cava, which in turn drain into the right atrium of the heart before its blood is taken back to the lungs for oxygenation. So the walls of the veins, unlike those of the arteries and arterioles, are easily distended and can expand to hold more blood without much increase in intravascular pressure. Thus, because of this one, they are referred to as capacitance vessels as compared to resistance vessels for the arterioles. They are innervated and their smooth muscles respond to non-adrenergic stimulation, pushing the blood into the heart and the arterial side of the circulation. So the intima of the lymph veins is normally folded at intervals to form these venous valves. And these venous valves are very important because they prevent backflow, retrograde flow. The lymphatic vessels are made up of endothelial tubes. Remember, fluid normally enter through them through loose junctions between the endothelial cells. the work of the lymphatics is to drain into large endothelial tubes that have valves and the contractile walls containing smooth muscle so that the fluid they contain moves centrally. So the central lymphatics normally drain into the right and left subclavian veins. Thus, lymphatic system will drain excessive fluid from the tissues, that is from the interstitial space, back to the vascular system. Okay? It's good to know that both systolic and diastolic in the aorta and large vessels is usually stable and there is usually a large pulse pressure. So the normal blood pressure is about 121 over 80 millimeters of mercury in healthy young adults. In the arterioles, there is usually a sharp drop which falls steadily in the venous system to about 5 millimeters of mercury at the entrance of the vena cava to the right atrium. So blood velocity falls in the arterioles and low in the capillaries due to the large total cross-sectional area. It increases again when it gets into the large vessels. So the pressure mentioned so far are those recorded with patients in supine position. Because of the weight of the blood, there is usually an increase in pressure in standing position in both arteries and veins of about 0.77 millimeters of mercury for each centimeter below the heart. Okay, below the heart is measured, and a corresponding decrease above the heart. So that's when the mean arterial pressure at the heart level is 100. Then the mean pressure in large artery in the foot of a standing average size adult will be 180 millimeters of mercury, and in the head it will be about 62 millimeters of mercury. Okay, because of the 0.77 Hb for centimeters below the heart. All right. Okay. Measurement of blood pressure can be done directly by inserting a needle into the artery or by auscultation using a sphygmanometer. Okay, so the normal blood pressure has already been indicated, but it's good to know that it could be affected by things like emotions and anxiety. So systolic blood pressure normally falls as much as 20 millimeters of mercury during sleep. In individuals with hypertension, the fall may be very minimal or may be absent. But blood pressure will normally rise with advancing age. But there is uncertainty about the magnitude of this rise. So individuals with mild hypertension that is untreated show a more rapid rise in systolic pressure. Diastolic pressure also rises, then starts to fall in middle ages as stiffness of arterioles increases. Consequently, pulse pressure normally rises with advancing age. When you look at capillary circulation, in capillaries, the speed of blood flow is decreased because of the large total cross-sectional area. Obviously, most of the net movement of substances out of capillaries occurs at its arteriolar end, where the net pressure gradient is outward primarily because of the hydrostatic pressure in the capillary, which is greater than the oncotic pressure. So as capillary resistance and filtration progressively cause an decrease in the hydrostatic pressure along the length of the vessels, the inwardly directed oncotic pressure gradient becomes greater than the hydrostatic pressure gradient, so that at the venular end fluid is reabsorbed. So any excess solute and solvent in the tissue is picked up by the lymph vessels and moved to the venous circulation by the main lymphatic ducts. So hypertension is not a single disease, but is a syndrome, okay, with multiple causes. In cases where the cause is unknown, you find that these cases will be lumped together under the term essential hypertension or primary hypertension. But when the cause is known, the hypertension will be referred to as secondary hypertension. So, generally, we can try to give some differences between primary hypertension and secondary hypertension. So, for the primary hypertension, you find that this hypertension without specific identifiable causes often develops gradually over time due to combination of genetic and lifestyle factors. While secondary hypertension results from underlying health condition or specific cause such as kidney disease, hormonal disorders, or medication side effects. In terms of prevalence, primary hypertensions account for about majority, that's about 90 to 95% of hypertension cases. This is different from secondary hypertension, which only accounts for a small percentage of about 5 to 10 cases of hypertension. In terms of the age of onset, primary hypertension develops in the middle age and later, while secondary hypertension can occur at any time, including childhood. In terms of causes, primary hypertension is caused by multifactorial, involving genetic predisposition, lifestyle factors such as diet, exercise, stress, and environmental influences. This is different from secondary hypertension, which is caused by an underlying condition, could be a medication, could be a specific disease process that raises the blood pressure. Primary hypertension, in terms of control and management, it's often managed with lifestyle modification, could be diet, exercise, weight control, and if necessary, use of antihypertensive medication. Secondary hypertension, on the other hand, management focuses on treating the underlying cause or the conditions. Blood pressure control often requires addressing the root problem. Okay, good. Primary hypertension, in terms of prognosis, generally responds well to lifestyle changes and medication, while secondary hypertension, prognosis depends on the underlying conditions. So effective management of the underlying cause may lead to better blood pressure control. Lastly, in terms of screening for underlying causes, you find that primary hypertension typically, specifically underlying causes, are not identified through this routine screening. However, for the secondary hypertension, thorough medical evaluation is necessary to identify the underlying condition causing the hypertension. So the blood pressure, when you look at the systolic, it should be less than 120, and the diastolic pressure should be less than 80 millimeters of mercury. So hypertension is generally the arterial pressure of greater than 140-90 millimeters of mercury in adults, at least 3 consecutive visits to the doctor's visits. Remember, this is the landmark, okay? This is the iconic number, 140 over 90, all right? So people whose blood pressure is between normal and 140 over 90 are considered as pre-hypertensive, and these pre-hypertensive people, they need to modify their lifestyle to lower their blood pressure to below 120 over 100 millimeters of mercury. Systolic pressure normally rises throughout life, and diastolic also rise, but it will rise until you get to 50 to 60 years, then it falls. So the pulse pressure is going to continue to increase. Remember, the most common cause of hypertension is increased peripheral vascular resistance. Other factors could include increase in cardiac output, increased blood volume, and increased blood viscosity. In terms of clinical presentation of hypertension, we're saying that hypertension is discovered during routine screening or when patient is seeking medical advice for complication caused by the disease. Remember, the complication could be serious and potentially fatal, and they could include things like MI, myocardial infarction, CHF, congestive heart failure, thrombotic and hemorrhagic strokes, hypertensive encephalopathy, and renal failure. And this is why this hypertension is normally referred to as silent killer. So observable changes are generally found only in advanced cases. and they could include hypertensive retinopathy, retinal hemorrhages and exudates, along with swelling of the optic nerve head, that is papilledema, left ventricular hypertrophy, cardiac enlargement. Remember, if it's a patient, also you need to listen over the with a stethoscope over the kidneys, because renal hypertension could lead to narrowing of renal arteries, which may cause bruits. In patients with hypertension, the condition is usually benign and progresses slowly, and in others, it could progress rapidly. So on average, you find untreated hypertension could reduce someone's life expectancy by 10 to 15 years. So it's worthy looking at it, guys. You find that in those cases, atherosclerosis will be accelerated, and this in turn leads to ischemic heart disease with angina pectoralis, myocardial infarction, thrombotic strokes, cerebral hemorrhages, and renal failure. Another complications of severe hypertension is hypertensive encephalopathy, in which there is normally patients will present with CNS disorders like confusion, disorganized consciousness, and seizures. In the case of malignant hypertension, there is widespread fibroid necrosis of the media, okay, and the intima fibrosis in the arterioles, narrowing them and leading to progressive severe retinopathy, congestive heart failure, renal failure. If untreated, you find that malignant hypertension is usually fatal in 1 year. Okay, so symptoms could lead to a hypertension emergency, which could hypertension crisis, which could be urgency or emergency. In terms of definition, hypertension urgency, this is a severe elevation in blood pressure. Okay, should be greater than 120, 180 for systolic, or greater than 120 for diastolic without acute target organ damage or symptoms. Emergency, on the other hand, we have severe elevation in blood pressure greater than the values you have mentioned, but it's associated with acute life-threatening target organ damage or symptoms. In terms of symptoms, hypertension urgency may have mild symptoms such as severe headache, but without acute organ damage. Hypertension emergency, on the other hand, often is accompanied by symptoms such as severe headache, shortness of breath, chest pain, blood vision, neurological deficits, or signs of organ failure. In terms of organ damage, we find that hypertension urgency there is no acute life-threatening organ damage at the time of evaluation. This is, however, different with the hypertension emergency, where it involves acute life-threatening target organ damage, could be the brain, could be the heart, or the kidneys, or sometimes symptoms indicating potential organ damage. In terms of immediate medical attention, hypertension emergency, we find that medical evaluation and adjustment of hypertensive medication are required, but hospitalization is not always necessary. But hypertension emergency requires immediate hospitalization and intravenous IV medication to lower blood pressure gradually and prevent further complication. The treatment goal, find that this gradual reduction of blood pressure over 24 to 48 hours. Whereas emergency, there is rapid controlled reduction of blood pressure to prevent further complication, typically achieved within minutes to hours. In terms of management location, hypertension urgency can be managed as an outpatient setting, but close medical supervision is necessary. While emergency requires intensive care and management in a hospital setting. Outlook, you find that hypertension urgency generally better prognosis, as it does not involve immediate organ failure. However, for hypertension emergency, this is a serious condition with high risk for mortality or long-term disability if not promptly and properly managed. So guys, in case we have a drop in blood pressure or drop in fluid volume, either through vomiting or diarrhea or drop in blood pressure by hemorrhage. Okay, we normally activate the renin-angiotensin system, whereby the kidneys, the juxtaglomerular apparatus, are going to release renin from the kidney. At the same time, the liver is going to increase, it will produce angiotensinogen. Remember, the liver will produce more angiotensinogen if you have more glucose in the body. Okay? Okay, and that's how it explains how hyperglycemia could result in hypertension. So the renin acts on the angiotensin released by the liver to form angiotensin 1. Angiotensin 1 is a weak vasoconstrictor, okay? A weak vasoconstrictor. So to come up with a more potent vasoconstrictor, the angiotensin 1 will be converted to angiotensin 2 by the use of the ACE. This is angiotensin converting enzyme that is normally released from the lungs. Remember, this enzyme could also be released from ectopic areas in case of tumors. Okay, so once this enzyme has been released, this enzyme will now be converted to convert angiotensin 1 to angiotensin 2. Remember, angiotensin 2 can act directly on the blood vessels because we are saying it's a potent vasoconstrictor. It stimulates vasoconstriction and narrowing, which consequently lead to increase in blood pressure. Also, it's going to act on the adrenal medulla, okay, at the adrenal cortex, specifically the zona glomerulosa, to release mineralocorticoid by the name aldosterone. And it's aldosterone that is going to act on the kidneys again to increase absorption of sodium chloride and water. And this is going to increase the blood volume, which consequently increases the blood pressure. And that's how the renin-angiotensin aldosterone system works. So this informs the management of this. Okay, so remember, in all forms of hypertension, modern treatment with adrenergic blocking drugs, inhibitors of renin-angiotensin system, calcium channel inhibitors, diuretic, will reduce the BP usually to normal levels. In addition, with this treatment, delay or prevent of complication also lengthens the life expectancy. Remember, we said hypertension is capable of reducing life expectancy of someone by 10 to 20 years, which is so much significance. However, they are not curative, especially for the essential hypertension, the primary hypertension, so they must be continued indefinitely. Thus, essential hypertension is like diabetes mellitus, okay? It can be controlled but not cured. So if the cause of hypertension can be identified as for the secondary hypertension, its treatment may result in a cure. Consequently, it's important to identify such cases. So here is a summary of the drugs that we can use to treat hypertension, starting with the diuretics, which work by increasing urine production, reducing blood pressure and cardiac output. And good example could have the furosemide or hydrochlorothiazide. Okay, beta blockers. These beta blockers, they block beta receptors, reducing heart rate and cardiac output. Examples could have atenolol, delols, propanolol, metoprolol. Okay, ACE inhibitors inhibit angiotensin converting enzymes. Okay, remember this one is done that will be converting angiotensin 1 to angiotensin 2, which is a potent vasoconstrictor. So we use the prils, enalapril, the sinopril. Okay, remember they normally have cough as a side effect. You also have angiotensin 2 receptor blockers. We call them the statins, okay, like irbesartan, valsartan, losartan. They normally block angiotensin 2 receptor, dilating the blood vessels. Also have calcium channel blockers, okay. They block calcium channel in the heart and blood vessels, reducing heart rate and vasodilation. For example, we'll have amlodipine, diltiazem, verapamil. We also have alpha blockers. They block alpha receptors relaxing blood vessels like the doxazosin, prazosin, derazocin. Alpha 2 receptor agonist. These one they stimulate alpha 2 receptors. Alpha 2 is reducing sympathetic outflow like clonidine and methyl dopa. Lastly, we have the direct vasodilators. This one they dilate blood vessels directly like hydralazine and minoxidil. Okay, and that's so good. So, lastly, we have the causes of hypertension. The causes of hypertension include the coarctation of aorta. We have salt sensitivity. We have renal abnormalities, acute and chronic glomerulonephritis, Liddle's syndrome. Remember, this is an abnormal sodium retention by the kidneys, which will be having an expanded fluid volume, producing hypertension, but no increase in circulating mineralocorticoids. We also have abnormalities of the renin-angiotensin system, which we have already indicated. Also, adrenal gland disorders like pheochromocytoma that is involved in production of catecholamines as a result of a tumor on the adrenal medulla. Glucocorticoid excess. Remember, glucocorticoids are going to increase the release of angiotensin by the liver, okay? And this one will definitely increase circulating angiotensin too, which, unless the feedback inhibition of renin is able to compensate, will lead to hypertension. We also have excess secretion of catecholamines still from the pheochromocytoma. Then you have the neurological disorders. Okay, so remember, in managing a patient with suffering from hypertension, you're going to take history, you're going to come up with nursing diagnosis, and nursing diagnosis could be like ineffective health management related to lack of knowledge regarding treatment and control of disease process, as evidenced by patient unwillingness of the management unaware of the hospital management strategies, including dietary changes and medication compliance. We also have non-compliance related to therapeutic regimen, as evidenced by patients' failure to adhere to the prescribed drugs, dietary restrictions, and lifestyle modification, jeopardizing the blood pressure control and overall health outcome. Risk for complication related to uncontrolled hypertension, as evidenced by elevated blood pressure reading, obesity, and lack of adherence to the prescribed medication. Okay. Okay, so you need to support the adherence, you need to educate on the disease process, you need to encourage consultation with dietitians, support groups, encourage, educate on self-care. Also need to promote home community-based care, ensure community continuity of care, and monitor disease progress, especially early detection and extent of the involving target organs. All right. So guys, you need to be able to know when is a person considered to be hypertensive, what are the causes of hypertension, okay, what is the pathophysiology of hypertension, what do you mean by mean arterial pressure, and lastly describe a goal of nursing a hypertensive patient and outline key disease management areas. Thank you so much guys. I hope this lecture has been informative. Kindly take care and see you again.